Hi guys. So this is just going to be a short lecture on immunizations. I'm not going to go through every single vaccine because that would take forever and probably not be all that beneficial for you guys. There's plenty of information out there, specifically on the CDC website, which has a special section dedicated to vaccines. It's got all the schedules and updates and what to do if somebody's behind on their schedule, or if somebody missed a dose or when they should get a booster, all those types of things, and contraindications and stuff. I'm going to walk through a little bit of that, but just for your reference, it's all on the CDC site. So some background on vaccines. So what's the purpose of vaccination? Well, really, it's just to stimulate the active immune system to respond to a specific antigen, but you need to be able to do this without causing a pathogenic response. So obviously, you don't want to cause disease in people. So the vaccine has to be antigenic, but not pathogenic, and that's where all the science comes into play. So how can we basically trick the body into thinking they've been exposed to certain disease when in actuality they haven't? And the goal is to develop antibodies against this specific pathogen without causing harm to your patient. Vaccines have been incredibly successful. They're pretty much widely accepted as one of the greatest public health initiatives in preventative medicine. The other one that's widely contributed to the success of the human race in recent history, and by recent history I mean kind of a while ago, but that's just clean water. Clean water and vaccines together have probably cut down on disease more than anything else we've accomplished as a human race. So they're pretty cool. And a lot of the diseases that we vaccinate against, we don't really think about much anymore because we don't really see them unless there's, an outbreak like the measles outbreak recently. So again, the CDC is a great resource. It's got all the schedules. It's got linked to literature and trials. It's got question and answers and all types of stuff like that. Well, there are a couple different types of vaccines. Attenuated live vaccines are treated to alter the pathogen somehow. So what these are is they can't induce a full-blown disease, but they may be they're an altered form of the disease, so they may be able to cause a more mild variation of a disease. Not a guarantee. In fact, most people probably don't experience any type of disease whatsoever, but they do have that possibility. So for that reason, we do avoid attenuated live vaccines in pregnant patients, immunosuppressed population, very young children, and maybe some other situations. So just keep that in mind, and we're going to come back to this in a minute and talk about which ones specifically those are that are used currently. Inactivated vaccines are a way to produce vaccines where you're killing the organism by heat or chemical, and so you're giving a killed organism that's not shown to be clinically quite as effective as live attenuated, but it is an option. We don't really use inactivated very much, if at all, anymore. Toxoids would be detoxifying a bacterial endotoxin to allow your body to recognize the specific toxin that is being produced by the bacteria and develop an immune response against it. Polysaccharide and polypeptide are cellular fractions of an organism, so maybe a bacterial cell wall or capsule or something like that to present that to the body as opposed to the entire organism. And surface antigen or recombinant vaccines. Hepatitis B is an example of this, and what it is it's the specific gene is cloned, typo there, cloned in yeast cells where it is expressed but not pathogenic. So you have a specific type of yeast cell that's designed to clone the genes that are going to be presented to the body as the bait to take, if you will, for developing antibodies against hepatitis B. The immunology behind this on a cellular and molecular basis gets pretty complicated. If you're interested in it, I'd encourage you to look at some other resources. For time and also for the sake that I'm not an expert on cell and molecular biology, I'm not going to go into too much detail on that. All right, let's talk about the schedules first. So these are, we have child to 6 years, and then on the other side here you have 7 to 18 years. And you can see all the different schedules here and how everything works. I'm not really showing you this for any reason other than just to kind of show you what a broad picture of what we're vaccinating against today. Just some things to point out. Let's start with hepatitis B. Hepatitis B is an interesting one because it's the only one that's given before basically on the date of the birth. So idea is you get hepatitis B before you leave the hospital. Hepatitis B wasn't always vaccinated against. In fact, a while ago it was only recommended for people going into healthcare fields or high-risk populations, maybe because it is a bloodborne pathogen, but it's also associated with IV drug use and some other things like that. So if you were a high risk patient, they might consider giving it to you. So why do we give it to kids at birth? Well, the idea is that you're probably most likely to come in contact with hepatitis B during the first couple days of life because you are in the hospital. And being in the hospital means you have the potential for any type of accident that might have some kind of consequence, such as a needle stick exposure, accidental blood exposure. Very odd and rare things that we don't like to think about. But if you think about being in the hospital versus being at home, probably much more likely to get exposed to something like that in the hospital. So that's why that's why that one's recommended right away. A few of these other ones, I'm going to talk about Haemophilus a little bit specifically on a slide. Just use it as an example of a vaccine success story, and then you've got all these other ones. The thing is, by most patients, 6 months you're going to have a fair amount of vaccination going on, and then by 2 years of life you've essentially gotten everything. There's a few more things that kind of creep in, and if you've missed them, you can get a catch-up dose or something like that. The ones that come in later in life, we have the meningococcal vaccine, and you have the human papilloma virus vaccine, the HPV, starting at 11 and 12 years old. So anyway, if you're curious about this or want to know or want to talk to your patients about it who are concerned about the vaccine schedule and want to know how it works, I'd recommend just being familiar with it so that you can talk about any of your patients who are wondering about vaccines or like when to start or what vaccines to give when. But this is the current recommended schedule. All right, this is just to show you for adult patients. Let's say you get a patient who is behind on things, or maybe they haven't gotten their flu shot or something like that. It's like, when can you give it? What can you do? There's not a lot here that's contraindicated. In fact, pretty much everything is okay. Again, with the exception of those immunocompromised pregnant patients who can't get live attenuated vaccines, which would be varicella, zoster, measles, mumps, rubella, and also the live attenuated version of the influenza vaccine. However, we do have the injectable, that's the nasal one, by the way, the live attenuated. The injectable one is not a live attenuated vaccine. That one can be given to anyone. There's no central contraindication to that. So again, these references are easily available on the CDC website, so feel free to browse them at your own convenience. Okay, so live vaccines are something I've talked about a little bit. These are really the only common live vaccines we're using today. If you go to different countries, you may see other things being done. In the U.S. on our schedule, this is pretty much the only ones you're going to encounter. Now, I'm not going to say that's absolute because there could be some other unusual ones out there. Again, especially if you go to other countries in practice, but for the most part, this is what you're looking at. So we've got the FluMist, which is the intranasal influenza vaccine. And this is an option for multiple patients, but sometimes specifically I see it used a lot in the pediatric populations who don't want a shot to the arm, so they do the nasal one. There's debates on whether it's as effective. I think clinically it's been proven to be as effective, but there's some years even when there's some argument that it's more effective because it might work on some different strains of the influenza virus, or that the fact that it is a live attenuated might give a better immune response than the standard vaccine. And then you have the zoster, the MMR, and varicella down there too. So some contraindications or precautions to vaccines. There's not a lot of them out there, but we do want to be careful of some of these. So anaphylaxis, very unpredictable in most cases. There could be, usually it's due to some kind of a component of the vaccine. For example, some are used specifically the influenza vaccine with eggs, and there's an egg-free product on the market, so you could get around it with that. But for the most part, that could be a possible culprit. So we try and screen for people who have an egg allergy. Obviously, if you have an egg allergy, we don't want to give you the vaccine. But really, it's very difficult to predict, and especially in kids. In adults, usually they've been exposed to enough things where they might have had a reaction to something. But unfortunately, anaphylaxis to anything really, to food, drugs, vaccines, it's very unpredictable, and you don't really know until you try it in a lot of cases. So, we screen as best we can. We have medicine available. Any pharmacy doing vaccinations has to have an EpiPen on hand. So stuff like that is precautions like that are taken, I should say. We talked about immunodeficiency in pregnancy, avoiding the live attenuated. Immunosuppressive therapy. Usually, this is short term for the most part. If the immune system is being suppressed, if it's chronic suppression, you'd want to avoid your your live attenuated. If it's short term, for example, like a chemotherapy cycle, you could wait until the immune system recovers and then vaccinate, like in a kid who's undergoing chemotherapy. One thing about it should say response is not as good, not response is note is good. But one thing about immunosuppressive therapy to think about is that, and just general in the way your immune system functions in general, and this kind of bleeds into the acute illness bullet below this. But if your immune system is somewhat suppressed, or if it's ramped up fighting an infection, the likelihood of it responding to the vaccination in the way we want it to is not as good. So the problem is that you just aren't going to get good response from the vaccination in those cases. So you could give it. It's likely, like for example, if somebody's immunosuppressed and you give them a non-live attenuated vaccine, it's not going to hurt them, but it's just not going to be all that effective. And the same thing, the reason why they say not to give somebody a vaccine if they're feeling sick, or if they've had a fever recently or something like that, is mostly because it's just not going to be as effective. Also, having a fever, acute fever, could mask possibly an allergic reaction type symptoms. So that's another reason why we don't like to give vaccines to people in those situations. All right, so no vaccine talk would be complete without talking a little bit about the controversy, or like I like to say, lack thereof. I say lack thereof because I really don't think this is as big of a deal as people make it out to be. Unfortunately, the people who are vocal about being anti-vaccination are a very small minority, but, well, that's the fortunate part, I guess. The unfortunate part is that they're a very loud minority. And you can find all kinds of crazy stuff on the internet about people and their beliefs on why vaccinations aren't safe, why they choose not to vaccinate their children. But the majority population, the majority of the science community is behind. And by majority, I probably could safely say 99% of all physicians in the United States would probably support vaccination. I think that there's a couple people, and every once in a while you hear like there's that cardiologist in Arizona who's outspoken about being anti-vaccination. There's some people who have varying degrees and PhDs and certain things that every once in a while come out, but the more you dig into them, the more you find holes in their theories. And but let's talk a little bit about the history, because I think the best thing to do is to be informed about where this all came about and why people are afraid of vaccines. So excuse me. So let's talk about autism and vaccines. This was really where everything came about, and it started mostly in 1998. A doctor named Andrew Wakefield, who is a British physician, published a paper in the Lancet journal, which is a very respectable journal. And all it was is a sample size of 12 children, which, if you know anything about literature, means absolutely nothing, showed that the MMR vaccine could ultimately potentially damage brain tissue. Now, what the interesting thing about this is that they made a whole bunch of correlations to say, well, if the vaccines could damage brain tissue, then potentially that could lead to autism. So that was the reason, saying that they're essentially neurotoxic. Eventually, with enough complaints of people, other people in the medical community saying that this study really wasn't high quality enough, and the sample size didn't matter, and the results were questionable. Enough people complained to Lancet, where they actually retracted the paper. Eventually, Dr. Wakefield himself was stripped of his medical license in the United Kingdom for falsifying information and other things. And but that didn't stop other people from saying, well, maybe he's onto something, and trying to look at epidemiological data. And really, there's been a lot of studies because of this really small poorly done study. There's been a lot of research and research money poured into figuring out, okay, is this really looking into? And ultimately, everything that's been studied so far has said no. There's no correlation to autism, unfortunately. Well, fortunately for vaccines, unfortunately for the people who are really looking for the answers to why their children are autistic. And as a father, I understand that there's something wrong with your kid. You really want to find out why. What's the problem? Is there something that I did or something I can do to help people not not become autistic? And so where people are looking for answers, I think they're just looking in the wrong places. And I think as a society, we can very safely close the book on vaccines and autism. I just don't think, and I would say the majority of the medical community is with me on this, that there's absolutely no link to autism. You get the problem with celebrities like Jenny McCarthy, who really have no credibility whatsoever. But again, they're a small minority of people that are really loud, and they make a lot of noise about this. So they really want to make things safe. Jenny McCarthy, I think, has said, actually, she's like, I'm not anti-vaccine, I'm anti-harmful vaccines. But the problem is that vaccines, as we know it, aren't harmful unless you're allergic to them. So it's questionable when you get these loud celebrities and people who take a stand on it. And it's actually been interesting, I think, with the whole measles outbreak in California. We've actually seen the opposite now, where a lot of celebrities and a lot of physicians are standing up and saying, no, okay, we need to be more aware of this is an issue. We need to put our foot down and say, this is not okay to be so anti-vaccination. Like being anti-vaccination associating with being anti-science. Okay, you can't just ignore all the scientific evidence. And if you do, you're kind of living in a fantasy land. And that's the message, I think, that is clear and based on the science. Now, things could always change, and maybe next year there'll be a big scientific slew of evidence, but I highly doubt it. I think it's been pretty much thoroughly searched over, this theory, and I don't think that there's anything to it. The one thing I will mention also is thimerosal. This is a mercury-based preservative. This was kind of considered by most vaccine critics as the neurotoxic culprit. Just quickly about thimerosal. Thimerosal is one form of mercury that is ingested. It's a little bit different than the type of mercury you might get from fish, and in fact, it eliminates from the body quite a bit faster. The question mark with it is it's a little bit more lipophilic, meaning it can get into the blood-brain barrier quicker, but the amount of mercury you get from every vaccine combined, which is essentially nothing in this point, doesn't really make sense with this being a theory. In fact, thimerosal has been removed from essentially every vaccine on the market. The one question is, and it was never really in many vaccines to begin with. For example, MMR vaccine, which is what Wakefield's paper looked at, never contained any thimerosal to begin with. So that whole link means nothing. But you do have thimerosal still in some of the multi-dose vaccines. For example, a multi-dose flu shot that a lot of community pharmacies use to save on cost, that has thimerosal in it. It's a preservative, allowing them to keep the vial preserved after puncturing it, and because it has like 10 doses in one vial, so they can withdraw from that vial without having any problem that way. So but if you're at a place where they use the individual flu shots that are the single dose, like we do at our hospital when we do employee vaccines, they don't have any thimerosal in them. Some other common public concerns, just to talk about them. Vaccine overload is something that comes up a lot, about people concerned that we're overwhelming the immune system and weakening it by giving too many vaccines. And a lot of this came about, there's a case that was settled with the CDC and vaccine. CDC has a vaccine injury compensation program, which actually usually compensates people, I believe, for things like allergic or anaphylactic type reactions. And a girl whose encephalopathy worsened after administration of multiple vaccines was actually compensated by the Vaccine Injury Compensation Program. So a lot of people were like, well, is it because they got too many vaccines? And the CDC has said, no, this isn't. They haven't really released all the information about the case, but they say this isn't because we think vaccines caused it. It's more of a maybe they can't rule it out, so there is some sort of compensation being happened. I'm not sure, but the CDC has tried to put a positive spin on it. Now, obviously, there's many people who would see that as negative. So the question mark is this really a big deal? Well, the infant immune system think about being an infant, and well, obviously we can't think about that. We don't remember that. But if you're an infant, you're essentially born with very little immunity other than what you've gotten from your mother. And then your immune system is immediately building an incredible response to a lot of things. Think of how much stuff you're getting exposed to on a daily basis that your body's never seen before. Some models and some scientists predict that you could likely have an infant respond to thousands of vaccines simultaneously with no loss in step from the immune system's capability. So the immune system can react very efficiently to a lot of different stimuli, and it has to as a young child. It just has, that's the way it has to work. So it's really not a significant risk, and the amount of vaccines we give likely has no impact on overwhelming the immune system whatsoever. And they've done studies on combining vaccines during a visit. Doesn't change how the child's immune system responds. They've looked at do you give less, do you give more, and it really doesn't have any impact, at least from a clinical data point of view. We've been able to, as vaccines have developed over time, we've been able to say, okay, how much immunogenic material do we really need to get that immune response? And just like a lot of times when we develop drugs, sometimes we start out with a higher dose and realize, you know what, people actually get an effective response from a lower dose. And that happened a lot with some older drugs, specifically oral contraceptives are a great example of that. We use a lot lower doses of hormone than we used to when they first were developed. Same thing with vaccines and the immunogenic material. With growing amounts of scientific research, we've realized we just don't need as much. So if you do buy into this, you can know safely that there is a decreased amount, at least over the last several years. And then there's some people who have advocated that, well, we do think that this is a concern and people are getting too many vaccines, so let's spread out the vaccine schedule. It's a really awful idea, and you could end up increasing risk of death with that for our kids, and we really don't want to do that. I'm going to talk about an example with Haemophilus here in a minute, but spreading out the vaccine schedule is just, it's an awful idea. It really has no scientific basis to it. There's a couple of physicians that have advocated for it and written books about it. Again, really no science behind it, and it's really just theoretical at best. And of course, the longer you wait to give an immunization, the more at risk you are to get a certain disease. So problem. Aluminum's another one of those things that people don't like. They're like, oh, aluminum's neurotoxic, and aluminum actually is neurotoxic in high amounts. So what is aluminum? It's in vaccines, and it's used as an adjuvant to bolster immune response. So it helps the immune system react to certain things. The thing about aluminum and ingestion is that an infant will ingest plenty of aluminum from dietary sources as well. We all do. And the combined consumption from an average infant dietary source and vaccinations is thought to be very safe and very low, below any potential toxic threshold. So that's all we really know about aluminum, and there's no link to it really causing any problems. There may be other controversies out there. If you're interested in talking to me further, you can feel free to email me if you have any questions. But that's all I'm going to really talk about with that. Before I talk about Big Pharma a little bit, I'm just going to talk about working with patients who have some sort of opposing viewpoint to vaccines. And I think you get a couple different types of people. You probably get the people who have heard things or read maybe some of those sites on the internet, or read those, information published by those couple physicians out there that are anti-vaccine and are vocal about it and are concerned. But these patients may just want somebody like you to walk through the evidence with them, explain to them that the risks are low, and assuming you have a good trust and rapport with the patient, that may be enough to convince them to vaccinate. Then there's the other side of the coin where people may have made up their mind totally coming in it. There's probably not much you can do about that, and as a provider, you'll have to decide how you approach that, and it's probably going to be an individual circumstance type thing. But I found in my life it's difficult when somebody has a belief about something, even if it's not really founded in anything, and this applies to anything outside of vaccinations. You could say politics, religion, whatever. People get really adamant, myself included, on certain things, and it's hard to sway them, even if the evidence is very clear in one direction. Okay, so that's all I got to say about that. Now, on vaccines and Big Pharma, question is this just a big moneymaker for pharma? Actually, they're profitable, and especially in some of the developing countries where there's been some recent grants that have supported vaccination programs. Pharma has been making pretty good money off of them, but they don't really compare to once daily oral medications as far as money. The problem is that vaccine R&D is really expensive, and vaccine production is incredibly expensive. It's not like making a tablet. You have to invest a lot more money up front, and the profit margins are slim. Yes, they're making money, but there's not a lot of pharmaceutical companies that are in the vaccine game. It's really the big players that can afford to do it. Interestingly enough, at the beginning of the lecture, I said this is likely one of the biggest public health initiatives since clean water is the vaccination program. And some economists have tried to predict exactly how much, if you invest $1 in a vaccine, how much money does that save overall? And the point is that there's a lot of money being saved even if you look at conservative estimates on disease prevention. And we can do that by looking at disease rates pre-vaccination and post-vaccination and say, okay, well, how much did it cost to admit an infant to the pediatric ICU for several days for Haemophilus meningitis? And now how many less cases of that do we have today? And so that's a way we can do that. And even conservative models show that vaccines are likely saving billions and billions of healthcare dollars a year. So they can be expensive, yes, but down the road, you're getting a lot of savings worth. So it's kind of a moot point, I think. All right, so just a couple examples to point out some cool things about vaccines. So H influenza or Hib or Haemophilus type B, this was a leading cause of bacterial meningitis and bacterial disease in general in children less than 5 years old. 1 in 200 would develop invasive Hib prior to vaccination, and 66% of these were under 18 months. So this was a disease affecting really little kids. The vaccine was developed in the late 1980s, and the CD started reporting data in 1991 officially. There were some estimates earlier from various sources, but the CDC took it over in 1991 and really started getting good data. So they estimated about 20,000 cases per year in the 80s prior to vaccination. And between 2003 to 2010, average cases per year were 2,500, and only 398 involved children under 5. So if we look at historically what would have been that most of these cases were in children under 5, and now actually most of them are children over 5 or adult cases. So we've probably, due to vaccination, we've significantly eliminated or reduced substantially the amount of Haemophilus influenza type B. It's a very invasive illness that in bacterial meningitis has a really high mortality rate. And so this is one of the cases where one of the people who was proposing extending the vaccine schedule to space it out a little bit more, I think one of their propositions was moving Haemophilus to like 2 years of age. Well, that's going to end up with dead children due to meningitis. And that's why just looking at some of this data, you can see the impact we're having. And that's why it's important to me that kids get vaccinated on schedule and on time, and they get all their vaccines, because we don't want kids getting bacterial meningitis. At least, I don't want my son getting bacterial meningitis, that's for sure. That's all I really want to say about vaccines. Again, if you have any questions or comments, feel free to email me. I'm not trying to be controversial here. I'm just trying to present the facts as I see them and the facts as science and the CDC presents them. All this information essentially was taken from a couple articles, and most of it was from the CDC itself. So you can get all this information there. And I encourage you to do your own research and look into these issues on your own. Just be wary of the information out there on the internet. There's a lot of people who claim to be experts who don't really say much. So go to the literature, look at the data, and analyze it from a scientific perspective, and you'll be okay, I think. So thanks for listening, guys, and we'll talk about antibiotics next time you hear from me. Thanks.